Evening friends, I'm Dr. Sushant Soni. I'm from AIIMS Delhi and I'm the pathology faculty with the institute Dr. Bhatia's. Now starting with the NEET January 2020 pathology discussion. Before we go further, let us first have a look at the general paper and what was the consensus among the students. Bache, you very well know that 300 questions came in the paper. Out of these 300 questions, close to 200 questions were clinically oriented. That is, they told the history of the age of the patient was given, the investigations, you were not asked the diagnosis, you were asked a step further in that. Firstly, so it was an extremely lengthy paper. Each question, around 200 of those, had 8 or more lines. The options were lengthier, so that what the students said was they had to think faster on their feet. The time allotted for each particular question by the examiner was less. First point. Next, out of these 300 questions, close to 60 were image based. So what the examination board has done is they are gradually shifting the pattern from NEET to next. It is becoming more clinically oriented. More USMLE based approach is coming, so we will see this throughout the year. Majority of the questions that we'll be practicing will be more USMLE based. They will be more clinically oriented. Talking with respect to pathology, pathology had about 22 to 24 questions which came in the paper, out of which one question was absolutely new, the translocation 1216 lipoma one. That was the one which was new. It was a new topic which was introduced. The remaining questions were exactly from your notes or were just a step above it and could have been solved on the basis of approach. We will be seeing that. So let us start with the pathology discussion of the NEET January 2020. Starting with the first question, 5-year-old child, 5-year child with bleeding per rectum, diagnosis. Dekho, these were the 4 options given: Peutz-Jeghers syndrome, juvenile adenomas, juvenile polyp, tubular adenomas, villus adenoma. One thing is certain, tubular and villus adenomas, this we have seen what they look like in our routine classes. This is not like tubules, or this does not look like villi. I will show it to you. Peutz-Jeghers syndrome, the median age is 11 years, with the most common location being Peutz-Jeghers, jejunum. Remember we have discussed this. Peutz-Jeghers, the second alphabet is J, jejunum. The history was pointing towards juvenile polyp. History itself was pointing towards juvenile polyp, which occurs in children, that is age less than 5 years, with most common location being rectum, leading to bleeding per rectum. And what you see in the microscopy is the presence of dilated glands. What you see are, some are much larger, some are smaller, dilated glands with columnar lining, juvenile polyp. Next, so let us start with the basics in this. This is an important topic. I can divide the intestinal polyps into 2 types, non-neoplastic and neoplastic. Which are more common? Non-neoplastic. More common, non-neoplastic. Non-neoplastic intestinal polyps are 3 main, that is inflammatory, hyperplastic and hematomatous, versus adenomatous polyps which are neoplastic in nature. Next point, so in the options given in this question, we had 2 options. We had 2 options which were Peutz-Jeghers and juvenile, which were hematomatous polyps. Hematomatous polyps, they are Peutz-Jeghers syndrome. They are Peutz-Jeghers syndrome and juvenile polyps versus the other 2 options which were adenomatous polyps. Microscopically, I can divide adenomatous polyps into tubular adenomas and villus adenomas. Tubular and villus adenomas. So these were the options given. Starting with the hematomatous polyps. Hematomatous polyps, they are of 2 main types, juvenile and Peutz-Jeghers. Juvenile polyps, they are usually seen in children less than 5 years of age, with most common location being rectum. As a result, they present with rectal bleeding. Next, please put a star on this. This is a prospective AIIMS question. The mutated gene associated with juvenile polyp, SMAD4 versus, and we have already seen what they look like, versus Peutz-Jeghers syndrome. Firstly, it is autosomal dominant in nature, autosomal dominant with a median age of 11 years. Next, it is a syndrome with multiple polyps in the intestine, that is multiple GI hematomatous polyps with mucocutaneous hyperpigmentation, with mucocutaneous hyperpigmentation, and the sites of hyperpigmentation are around the oral cavity, buccal mucosa, nostrils, palms and soles, perianal and periscrotal lesion. These are the sites of hyperpigmentation. Next, microscopically. Next point, microscopically, they show the characteristic arborizing network of connective tissue with smooth muscle, lamina propria and glands, which is called as the classical Christmas tree appearance, which is the classical Christmas tree appearance associated with Peutz-Jeghers syndrome. I'll be showing it to you. Next, Peutz-Jeghers syndrome increases the risk of various malignancies like colon, pancreas, breast, lungs, which is age dependent. We have seen this in throughout the grand tests which we did the whole year, and the mutated gene is STK11 or LKB1. STK11 or LKB1, and this is the characteristic microscopy of Peutz-Jeghers syndrome. So in the question given, you very well knew that Peutz-Jeghers shows the Christmas tree appearance. As a result, even if you did not know that it is not juvenile polyp, the microscopy, but you could have ruled out Peutz-Jeghers syndrome very easily. Next, this gets us to our next microscopy, that is tubular adenomas. What you are able to see here is the presence of numerous tubules, tubular adenomas versus let us have a look at the scanner view. Scanner view, firstly, what is scanner? What power? 4x. देखो बच्चे, scanner 4x, low power 10x, high power 40x, 100x oil immersion. I'll repeat, 4x scanner, 10x low power, 40x high power, 100x oil immersion. What you see in this is the presence of numerous villi at the periphery, making this as villus adenoma, Next, so these were the four options given in the question: Peutz-Jeghers syndrome, juvenile polyp, tubular adenoma, villus. The answer was juvenile polyp. Let us go a step further. Diagnosis. This has already been asked in May AIIMS 2016. Nothing was written, just diagnosis, question mark and image. What you see here is a pedunculated structure which is enlarging into these four areas. What you have at the periphery is the presence of villi versus center, which are the tubules. So diagnosis, tubulovillous adenoma. Tubulovillous adenoma. Tubular adenomas, villus as well as tubulovillous, they belong to which pathway of colon cancer? They belong to the adenoma carcinoma pathway. Of colon cancer. We will be seeing this in detail just in 2 minutes. Before going further, let us have a look at the classification of neoplastic polyps. Microscopically, we can divide them into two types: tubular adenomas and villus adenomas. Tubular adenomas are more common. They are more common, 90%, versus villus adenomas, which have a higher risk of malignancy. So I can safely say the most common precancerous polyp, tubular adenoma. Why? Because tubular adenomas are so common that even though villus adenomas have a higher risk of malignancy, but the most common precancerous polyp, tubular adenoma. Next, so the first way to classify neoplastic polyps is on the basis of microscopy. Next, the next way to classify is size of the polyp. On the basis of size, less than 1.5 centimeter are usually benign, more than 2.5 centimeter are usually malignant in nature. And lastly, grossly, the neoplastic polyps are of two types. They can either be pedunculated, that is, they have a stalk They are either pedunculated or are sessile in nature. They are either pedunculated or are sessile in nature. Sessile polyps are more commonly villous. Sessile are more commonly villous, so they have a higher risk of malignancy. They are more commonly villous, so have a higher risk of malignancy. Next point. This gets us to an important prospective image. Diagnosis. Now, before we go to this, let us recap what we have learned till now. We know from our theory that there are two main pathways of colon cancer. The first is the APC WNT beta catenin pathway, where the genes associated are APC, WNT, beta catenin, and KRAS. This is the adenoma carcinoma pathway. This is the adenoma carcinoma pathway. This is the first pathway of colon cancer, adenoma carcinoma pathway, versus the second pathway, which is the MSI pathway. Before I go further, the adenoma carcinoma pathway, the precursor lesion, there are two pathways, so the precursor lesion will be different, the cancer associated will be different. The precursor lesion of the adenoma carcinoma pathway is tubular/villous adenomas, which in turn progresses to conventional adenocarcinoma, versus the MSI pathway. The second pathway is the microsatellite instability, also called as DNA mismatch repair pathway. Firstly, the genes involved. Genes in adenoma carcinoma pathway were APC, WNT, beta catenin, and KRAS. Genes in the adenoma carcinoma pathway, 4 genes. Versus the MSI pathway, where the genes associated start with M. MUTYH, MSH2, MSH6, MLH1. All the genes throughout your 5.5 years of MBBS, you will not study these genes anywhere except with the MSI pathway. All the genes, they start with M. MUTYH, MSH2, MSH6, MLH1. The only exception to this is PMS1 and 2. Next point, precursor lesion. The precursor lesion of the MSI pathway is sessile serrated adenoma. The precursor lesion is SSA, that is sessile serrated adenoma, which progresses to mucinous adenocarcinoma. So let us have a look at this microscopy now. Firstly, the minute you see this slide, you are able to make out that this is not adenocarcinoma. Adenocarcinoma, we have seen this, it shows the presence of glands with loss of nuclear polarity. This is not malignancy yet. It is precursor lesion. Which one? Is it tubular or villous adenoma? No, it is SSA, sessile serrated adenoma. See, knife shows the presence of serrations. It has serrated edges. Similarly, what you see here are all the serrations. What you see here are the serrations seen in sessile serrated adenoma. This is an important microscopy bache and an important MCQ also. Prospective question, have a good look at this. Sessile serrated adenoma, which is the precursor lesion of MSI pathway. Next point. This gets us to our next question, that is graft between identical twins. Very easy, pretty straightforward. I'm sure nobody would have gone wrong in this. It is called as an isograft. Graft between identical twins, isograft. Next point, same individual, own organ, yes, same individual, autograft. Next, same species, allograft versus different species, xenograft. Nothing major. Autograft, isograft, allograft, xenograft. Not important. I'm sure all of you would have been right in this. Next. This gets us to our next question and an important one. Diagnosis. Nothing was written, it was a no history slide. Diagnosis. See बच्चे, this is an electron microscopy. This is electron microscopy. Throughout our revision for the NEET PG, that is January NEET PG 2020, we had laid a lot of stress on the renal electron microscopies. This was one of the images which was discussed by me only. Now, what you see here is, normally in electron microscopy, the point of interest is marked with an arrow. So this is the point of interest. So what we have here is the basement membrane. Outside the basement membrane are the visceral epithelial cells which show loss of foot processes. So this is associated with loss or effacement of effacement of foot processes of podocytes, which is the diagnostic hallmark of minimal change disease, MCD, minimal change disease. Next point, have a good look at the question. Diffuse effacement of food processes is diagnostic of minimal change disease with an unremarkable light microscopy. First question. Next, diffuse effacement of food processes is seen in minimal change disease, FSGS and Berger's disease. It is seen in all three, but it is diagnostic in MCD with a normal light microscopy. Next point, we will be seeing the theory portion of MCD in detail just in 10 seconds. Let us have a look first at normal followed by disease. See, this is the capillary lumen with the gray color being the basement membrane, and this was the basement membrane, and these are the visceral epithelial cells or podocytes. This is normal. What you see here is again the lumen with the basement membrane with presence of podocytes. This is normal. Next, the second image shows you the basement membrane with effacement of the foot processes of podocytes. Diagnosis MCD, minimal change disease. Next point. So let us have a look at MCD, minimal change disease. First point, it is also called as lipoid nephrosis. This is because microscopically it is associated with lipid deposition in distal tubules. Lipoid nephrosis, not concerned. Next, you already know that it is the most common nephrotic syndrome in children. You know this. Children, so median age 2 to 6 years. Next, light microscopy is unremarkable or no change. The importance of this is, irrespective of the light microscopic image being given to you, you will never mark the answer as MCD because MCD has no change. Next, the diagnostic hallmark is electron microscopy, which shows diffuse effacement of food processes of podocytes. Next, minimal change disease. The name tells you minimal change. So there is no antigen antibody complex. So immunofluorescence is no deposit. Next, it is seen in children. Let's have a soft heart for kids. So it has an excellent response to steroids, hence good prognosis. The classical word used is, it has dramatic response to steroids, good prognosis. This is MCD, minimal change disease. Next, this gets us to our next question. 45-year person, chronic smoker, came to clinic with cough. Physical examination of the patient and physician examines, takes a biopsy. Microscopy was given. Which cellular change is happening in this patient? Dekho bache, there were 2 pointers in the history itself. Smoker, cough. Even if you knew nothing about the slide, it was a case of metaplasia. But I always say this in all my live classes. The history is simply a pointer towards diagnosis in an image-based question. So always have a look at the image first. What you see here are the normal pseudostratified ciliated columnar epithelium. Normal pseudostratified ciliated columnar which is changing to squamous, which is changing to squamous. This is called as squamous metaplasia. This is squamous metaplasia seen in smokers. So the answer was metaplasia. Which cellular change was seen in the slide? Metaplasia. Next point. Next point. Let us have a look at the next slide. Now this again is a prospective question and this is a good image. See, metaplasia, there are two main epithelial metaplasias. Squamous metaplasia, that is normal lining changes to squamous, and columnar or intestinal metaplasia. We use the word intestinal because it has columnar plus Barrett cells. So we use the word intestinal metaplasia, that is Barrett's esophagus. These are the two metaplasias. We'll have a look at both of these. Starting with the first image, what you see here is the normal stratified squamous epithelium. This is normal stratified squamous. Next, the blue arrow is the normal columnar epithelium. You're able to make this out. Normal columnar epithelium with nuclei which are present. Normal columnar epithelium. So this is the squamocolumnar junction of the cervix. This is squamocolumnar junction of the cervix, showing this columnar getting converted to squamous. This getting converted to squamous. This again is squamous metaplasia. Columnar changing to squamous. Squamous metaplasia of the cervix. So this very well can be asked as the next prospective question on the slide. Next, a image that all of you know very well. Now, let us first start with microscopy. This is the normal stratified squamous, which is changing to columnar, with presence of goblet cells. All these white ones, these are the goblet cells. So squamous changing to columnar plus goblet, that is intestinal metaplasia. This is intestinal metaplasia. Called as Barrett's esophagus. Main risk factor being GRD, gastroesophageal reflux disease. Next, a variation of this question that can be asked is area marked with the question mark or area marked with arrows is answer stratified squamous या intestinal lining. Answer बच्चे. The area marked with the arrows, this is the glistening white. What you see here are two areas, velvety red and glistening white. Velvety red is Barrett's esophagus. Versus glistening white, which is the normal stratified squamous epithelium. Glistening white is the normal stratified squamous epithelium. This is Barrett's. Next, this gets us to our next question, that is diagnosis. Now we got multiple reviews of this from the students. Some told us that granuloma, everybody agreed that it was a slide of granuloma. The students were confused whether it was tubercular granuloma or sarcoid granuloma. So I'm showing you both the images. Firstly, let us have a look at this HND, hematoxylin deoxin stain. What you are able to see, even if you are not able to make out the granulomas, but I guess all of us are able to make out the giant cells. These are cells with multiple nuclei. This is a giant cell in which nuclei are arranged at periphery, giving it the classical horseshoe shaped appearance. Seen in Langhans giant cell. Langerhans giant cell, which is a feature of tuberculosis. Next, what you see in the background are all the granulomas, So this is a slide of tuberculosis. This is what tubercular granulomas look like, TB. Versus, have a look at this. All these are again the granulomas. All these are granulomas with concentric laminated fibrosis. What you have in the background is the concentric laminated fibrosis, giving it a hard texture, which is seen in sarcoidosis, So it will be up to the students who gave the paper to decide whether it was a tubercular or a sarcoid granuloma. Next point, let us have one more look at sarcoidosis, the image seen. What you see here again is the presence of giant cells. All these are large cells with abundant nuclei, giant cells, with presence of stellate or star-shaped inclusions. What this shows is stellate or star-shaped inclusions, in giant cells, called as asteroid bodies, seen in sarcoidosis, called as asteroid bodies, seen in sarcoidosis. Next, this gets us to our next question, that is diagnosis. Now consider this as a no history slide. Whenever an image is given, always first look at the structure, organ, and then disease. What you see here is the presence of thyroid follicle with colloid in it, showing all these are nuclei, similar looking nuclei with a prominent nucleolus, This is the classical appearance of orphan annii nucleus, seen in PTC, seen in papillary thyroid carcinoma, orphan annii nucleus, PTC. Pretty straightforward, nothing major. This paper had two images from thyroid again. Thyroid is a topic which in the previous 2 years has been asked repeatedly. I guess there have been a total of 5 questions from thyroid. This paper showed you an image of PTC as well as Hashimoto's. This is PTC. Let us have a look at PTC, the theory part, in slight more detail. You very well know it is the most common thyroid cancer. If it is the most common, it has best prognosis. Point to be seen here is it is the most common post radiation exposure. First main point. Next, female predominant, younger age, 20 to 40 years, red and BRAF mutations, not mainly concerned. Next, microscopically, the diagnostic hallmark, is orphan annii nucleus, which is a clear nucleus with ground glass appearance and a prominent nucleolus. This was what we were saying. Next, it also shows the presence of pseudo inclusions. Pseudo means false inclusions, which are intranuclear vaginations or intranuclear grooves because of the cytoplasm. What this means is the cytoplasm of the cell involutes into the nucleus, giving rise to a pseudo inclusion. Lastly, PTC is also associated with semoma bodies. Please note, semoma body is not the diagnostic hallmark. Diagnostic hallmark is orphan annii nucleus. Why? Because there are numerous tumors with semoma bodies, which are answer PTC, papillary thyroid carcinoma. Next, papillary RCC, papillary renal cell carcinoma. Next, which tumor of the ovary? Serous or mucinous? Serous. Next, serous cyst adenocarcinoma, serous cyst adenocarcinoma, ovary. Next, mesothelioma, mesothelioma, meningioma, meningioma, and prolactinomas. Mesothelioma, meningioma, and prolactinomas. These are the tumors associated with Semoma bodies. Tumors associated with Semoma bodies. Diagnostic hallmark of PTC, orphan NAI nucleus. Next. This gets us to the next image which was asked. Again, a repeat standard question from thyroid. Be unbiased. Be unbiased. Parent organ, thyroid. What you see here is the presence of thyroid follicles with colloid in it, thyroid. Suppose left hand side was not given. You just had the right hand side image. What this shows us is dense lymphocytic infiltrate with well-defined germinal centers, with well-defined lighter areas, that is germinal centers. So you can confuse this with a lymph node. Now combine the two together. Combine the two together. Dense lymphocytic infiltrate with germinal centers, with entrapped thyroid, with entrapped thyroid. Diagnosis, Hashimoto's thyroiditis. Diagnosis, Hashimoto's thyroiditis. Nothing major. Again, I will consider this as a easy non-discriminatory question. Hashimoto's thyroiditis, you know that it is the most common cause of hypothyroidism in iodine sufficient areas. Next, Hashimoto's, it is autoimmune destruction of the gland, middle age, female predominant, genetics, CTLA4 and PTPN22. Genetically, CTLA4 and PTPN22. Next point, microscopically. Microscopically, the first main point with Hashimoto's is it is associated with atrophy of thyroid follicles, followed by entrapment of thyroid with germinal centers, well developed germinal centers. This was what we saw. Next point, important to be seen here is Hashimoto's can show the Hurdle cell or oxyphil change. This is an important prospective question. I will show you what it looks like. Hurdle cells, they are abundant large cells with abundant eosinophilic granular cytoplasm. Large cytoplasm which has granules in it. I'll show to you the Hurdle cell change. Next, diagnosis. Be unbiased. Let us finish off the thyroid microscopies quickly. What you see here is varying sizes of thyroid follicles. Some are very large, some are intermediate sized with a predominance of microfollicles. All these small, they are microfollicles. So microscopically, predominance of microfollicles, diagnosis, follicular neoplasm. Predominance of microfollicles, follicular neoplasm. I do not know whether it is adenoma or carcinoma. For the same, we need to see capsular invasion or metastasis. So this is plain and simple follicular neoplasm. Next, the most common thyroid malignancies, PTC, papillary thyroid carcinoma, followed by follicular carcinoma. So this gets us to follicular carcinoma. It is the second most common thyroid cancer, female predominant, and point to be noted here is FNAC is not diagnostic. This was easy last year's AIIMS question. FNAC is useful in all except follicular neoplasms, because to differentiate adenoma from carcinoma, we need to see invasion or metastasis. FNAC is non-diagnostic. Next, follicular carcinomas usually show hematogenous dissemination. In follicular neoplasms, hematogenous dissemination is more common versus papillary thyroid carcinoma versus PTC, in which lymphatic dissemination is more common, or lymphatic spread is more common. Lymphatic spread is more common. That was PTC. So let us see a variation of this. Follicular variant of PTC. PTC has various variants. We did not cover it in today's class, but PTC has various variants. Follicular variant of PTC, hematogenous spread is more common. Next point, follicular carcinoma microscopically shows abundance of microfollicles. Next, we have seen FNAC is non-diagnostic. We need to see capsular invasion or metastasis. Point to be noted here is, put a double star, the Hurdle cell change. Hurdle cell change can be seen. So both Hashimoto's as well as follicular can show Hurdle cell change. And this is what it looks like. An important prospective slide. Have a good look at this. Large cells, abundant granular cytoplasm. All these with a eccentric nucleus. All these are the Hurdle cells. All these are Hurdle cells. Hurdle cell neoplasm. Hurdle cell neoplasm. Next. This gets us to our next question, that is diagnosis. A pretty straightforward question. Pretty straightforward. You were given the second slide. The first image was not given. You were given the second slide in this. It was even a written question also. The rating was also there along with the options. Let us have a look at this. The first image shows the presence of villi crypts. Villi crypts. This is normal. This is normal. Versus the second image, which shows flattening of villi with crypt hyperplasia. It shows it has gotten flattened from the top. Flattening of villi with crypt hyperplasia. Top has gotten flattened, bottom is hypoplastic. As a result, total thickness of mucosa is maintained. So diagnosis, celiac disease. This was what was asked, celiac disease. Next, let us have a slight look at celiac. Celiac disease, this is gluten sensitive enteropathy. That means the person is sensitive to gluten. What is gluten? Gluten is a component of VROB. That is, the patient cannot eat wheat, rye, oats and barley. He cannot eat wheat, rye, oats, barley. Earlier it was asked what he can eat. He can eat maize. But today we have gluten-free products available everywhere. So what is more important in today's perspective is what he cannot eat, VROB. Next, MHC associated with this. It is associated with HLA DQ2/DQ8 in 98% of the patients. Next point, skin lesion, cytokine interleukin 5. Next point, skin lesion associated with celiac disease. Skin lesion, DH, that is dermatitis herpetiformis. Skin lesion associated DH, dermatitis herpetiformis. This is celiac disease. Asha, tell me 1-2 more points. Which part of the intestine is more severely affected? Proximal intestine or distal intestine? Most severely affected, proximal intestine. But how is the patient having food? Orally. So proximal intestine is more exposed to gluten. So more severely affected, proximal intestine. Next, when the patient stops having gluten, what will heal first? Distal intestine. Why? Because distal intestine was less severely damaged. So after stopping gluten, distal intestine heals first. This is celiac disease. Next, this gets us to our next question. That is 33-year male, 33-year male with 5-week history of calf pain, low-grade fever, CK is elevated, muscle biopsy shows eosinophils in peripheral blood. Peripheral blood shows eosinophilia. Which interleukin is responsible for increase in eosinophils? I know a lengthy question, a lot of lines were written in this, but the bottom line was which interleukin is responsible for eosinophil activation. Point to be seen here is the most potent activator of eosinophils, most potent activator, most potent activator of eosinophils is interleukin 5. Most potent activator of eosinophils, interleukin 5, followed by interleukin 4. So in the options given, 5 was not in the options. So the answer is interleukin 4. Which this was almost the same question which came in this November AIIMS 2 months ago. Dekho, November AIIMS, the questions asked were, let us have a look at this again. Interleukin with IgE and eosinophils, interleukin 5, followed by interleukin 4. November AIIMS asked you the most potent activator of basophils. For basophils, the most potent is interleukin 3, followed by interleukin 4. When this came in November AIIMS, interleukin 3 was not in the options. So again the answer was interleukin 4. Next, main mediator involved in sepsis. Sepsis, TNF alpha. Main mediator involved in sepsis, TNF alpha. Next, main cytokine responsible for ARDS, acute respiratory distress syndrome. So again the acute cytokines will be responsible for acute respiratory distress. Acute cytokines are interleukin 1, 6, 8, TNF alpha, which plays a major role in ARDS, interleukin 8. So cytokine responsible for ARDS, interleukin 8, interleukin 8. Next, this gets us to our next question, that is premature child with respiratory distress. Which cell will be affected? Point to be noted here is that as this is a premature child, this gets us to the next question. As this is a premature child, the diagnosis is neonatal respiratory distress syndrome. The diagnosis is neonatal respiratory distress syndrome. Neonatal respiratory distress syndrome. 2 questions came from this topic in this NEET exam. The first question was, which cell will be affected? The type 2 pneumocyte. It is obviously the type 2 pneumocytes which secretes affected. So type 2 pneumocytes. Next, the composition of lecithin was asked. We will have a look at that. Let us first start with neonatal respiratory distress syndrome. Neonatal respiratory distress, this is also called as hyaline membrane disease. Hyaline membrane disease, which is associated with hyaline layer deposition in peripheral air spaces. As hyaline membrane is getting deposited in the peripheral air spaces, the elasticity is lost. They are not able to expand, in turn leading to atelectasis. Sorry. Next point. So clinically, points to be seen is he is a preterm child. Preterm, so the lungs have not developed properly, but the weight is appropriate for gestational age. More common in males, associated with maternal diabetes, cesarean. Chest X-ray, this again is important. Chest X-ray shows ground glass appearance. Chest X-ray, ground glass appearance because of reticulogranular densities. Next, starting with pathogenesis of neonatal respiratory distress. Prematurity reduces the surfactant synthesis and storage, in turn leading to reduced surfactant, which increases alveolar surface tension. If the surface tension is high, the alveoli are not able to dilate, as a result of which it causes atelectasis, that is collapse of the lung. Atelectasis in turn causes uneven perfusion and hyperventilation, causing hypoxemia and carbon dioxide retention, which in turn causes acidosis. This acidosis, it is an independent risk factor for further reduced surfactant, firstly. Next, it causes pulmonary vasoconstriction, causing endothelial damage, causes hyperperfusion, endothelial damage, plasma leak, in turn leading to hyaline membrane deposition. And what is hyaline membrane? It is fibrin plus necrotic cells. This is the pathogenesis. This is the pathogenesis of neonatal respiratory distress syndrome. Next, the second question which came from this was on surfactant. Surfactant, the primary defect in respiratory distress syndrome is surfactant production, is surfactant. Firstly, let me rephrase. Firstly, surfactant, it consists of DPC, dipalmityl phosphatidyl choline. This was what was asked. It consists of dipalmityl phosphatidyl choline, that is lecithin, with phosphodiesterol and two groups of surfactant associated protein. The surfactant associated protein is a prospective question. How? There are two surfactant associated proteins. The first group is A and D, surfactant protein A and D, which play a role in innate immunity, which play a role in host defense, that is innate immunity. And the next is B and C. There were two surfactant associated proteins. AD, which play a role in innate immunity, BC, which are involved in reduction of surface tension and air liquid barrier. So which one play a role in dilatation of the alveoli? SPBC, the middle two, SPBC. This is surfactant and respiratory distress syndrome. Next, this gets us to a next image, that is translocation 1216 was asked. Translocation 1216 was asked, and you were with the image, and you were asked the diagnosis. Now, this was the new question which came in this NEET PG. Normally, in my live classes, I usually say that translocation 1216, lipoma, liposarcoma. That was it. But this time, the examiners went a step further. They gave an image. Lipoma, you very well know, shows the presence of fat cells. Let us have a look at others. Pleomorphic lipoma. Let us have a look at others. Pleomorphic lipoma shows the presence of floret type giant cells. All these are the flower type giant cells, pleomorphic lipoma, with hyperchromatic spindle cells. With presence of fat spaces in between. All this is fat. This is pleomorphic lipoma. The next was spindle cell lipoma. Spindle cell, it is usually present in males' upper back. Males' upper back solitary, recurrence is uncommon. Not concerned. This is what spindle cell lipoma looks like. What you see here is the presence of fat with spindle cells. All these are the spindle cells with hyaline collagen bundles. This is spindle cell lipoma. I do not think this image was given. The review that I got from the students is there was a confusion between whether the image was pleomorphic lipoma or myxoid liposarcoma. Let us have a look at that. Liposarcomas. Firstly, they are the most common soft tissue sarcomas, accounting for 20%. Microscopically, they have three forms: well differentiated, myxoid, pleomorphic. Most common is the myxoid form. Firstly. And secondly, the diagnostic feature of liposarcoma is the presence of lipoblasts. The diagnostic feature of liposarcoma is the presence of lipoblasts. Next, this is what myxoid liposarcoma looks like. What you have here is the characteristic crow feet vessels. What you see here is the macrophyte vessels with interspersed lipoblasts, myxoid liposarcoma. So it will be up to the students to decide whether majority of the students told me that the answer was pleomorphic lipoma. That was the image given, translocation 1216, and this is myxoid liposarcoma. This we got less reviews about this, but this was a new question. Next, this gets us to our next question, an important one, and this was something I was after your life since January 2019. This was an extremely important topic, diseases of the immune system. We discussed it in every grand test. We discussed it after the November AIIMS also. Two questions came from this. First, November AIIMS, you had that dot plot which was 19 positive 40 negative hyper IgM syndrome. We discussed that in the AIIMS discussion. Now let us have a look at this question. What you see here is a child, 5-year child with history of recurrent infections, rashes. This is the rash which is being shown, history of recurrent infections, rashes and low platelets. Most probable diagnosis. This is a disease of adaptive immunity called as Wiskott-Eldridge syndrome. Diagnosis, Wiskott-Eldridge syndrome. Now before we go further, though we have made this table repeatedly, but again an important table for AIIMS, I can divide the diseases of immune system. I can divide the diseases of the immune system into two categories, that is diseases of the innate immunity and diseases of adaptive immunity. Diseases of innate immunity and adaptive immunity. Diseases of adaptive immunity are further characterized into primary diseases of adaptive immunity and secondary or acquired. The main secondary or acquired is HIV, not concerned. Primary diseases of adaptive immunity are divided into B cell defects, T cell defects and combined B and T cell. B cell, T cell and combined B and T cell defects. What the November AIIMS asked you was the B cell defect. There are two main B cell defects. Bruton's X-linked A gamma globulinemia, hyper IgM syndrome, B cell defects. T cell defect is Digeorge syndrome, T cell, whereas combined B and T cell, this is a separate one lecture which I have already taken, so I am just speaking out. Combined B and T cell are SCID, severe combined immunodeficiency, which occurs because of adenosine deaminase deficiency. SCID, let me write it for you. SCID. Next is ataxia telangiectasia, ATM gene mutation, ataxia telangiectasia. Next was Wiskott-Eldridge syndrome. Next is Wiskott-Eldridge syndrome. This was what was asked, the combined B and T cell defect. Combined B and T cell defect. These are the diseases of adaptive immunity. You very well know the diseases of innate immunity, which are LAD1, leukocyte adhesion defect 1, which is a defect in adhesion. LAD2, leukocyte adhesion defect 2, which is a defect in rolling. CHS, Shediac-Higashi syndrome, defect in phagolysosome formation. Chronic granulomatous disease, defect in NADPH oxidase pathway, and MPO deficiency. These were the diseases of innate immunity. This is immune system defects. So coming to the question that was asked, Wiskott-Eldridge syndrome. Wiskott-Eldridge, it is a mutation in the VASP protein, Wiskott-Eldridge syndrome protein, X-linked mutation, clinically associated with low platelet count, thrombocytopenia, eczema and recurrent infections. Important point here is the antibodies. I always remember this as, normally people who keep on saying G sir, IgG, they remain normal. The ones with AM, that is AM the best, AM is low, IgM is low, whereas A and E is increased. This is how I remember it anyway, but this is asked. Viscott-Eldridge syndrome. Viscott-Eldridge syndrome. Next, this gets us to our next question. Very straightforward. Best prognostic M3 or ATRA is associated with treatment of PML rara. We have done this repeatedly. Acute promyelocytic leukemia. Acute promyelocytic leukemia. Acute promyelocytic leukemia. M3. M3. It is the best prognostic AML. Most common translocation being 15-17 PML rara. Therapy, ATRA, all-trans-retinoic acid. Most common cause of death in M3, DIC. So I can rephrase this as DIC is most common in which AML? M3. Easy. I'll be glad if you tell me this. CVS lesion associated with M3. Which vegetative endocarditis? There are 4 vegetative endocarditis: RHD, rheumatic heart disease, infective endocarditis, Libman sac, and non-bacterial thrombotic endocarditis, NBTE. CVS lesion with M3, NBTE. NBTE, non-bacterial thrombotic endocarditis, NBTE. The question which came in the paper was ATRA is associated with therapy of PML, RARA, M3. Next, this gets us to our next question, that is 20-year male, swelling wrist for 2 years, histopath shows spindle cells with Verrucke bodies. This again was a repeat standard question. This has already been asked in November AIIMS last year, that is November AIIMS 2016. Verrucke bodies associated with schwannoma. So I'm sure none of you would have gone wrong in this. This was a easy non-discriminatory question. Schwannoma. Schwannoma. It is a peripheral nerve sheath tumor. It is a benign tumor arising from peripheral nerves. Microscopically, it has 2 areas. Antony A, which are the hypercellular ones, and Antony B, which are the hypocellular loose edematous areas. Antony B, which are the hypocellular loose edematous areas. Next, schwannoma shows the presence of Verrucke bodies. Verrucke bodies, these are the tumor cells present in a palisaded manner with eosinophilic structure in between. This is what a Verrucke body looks like. I'll show it to you. Next, schwannoma arising from the vestibulocochlear nerve, that is cranial nerve 8, cranial nerve 8, located at the cerebellopontine angle, CP angle, is acoustic neuroma. Next, this is what schwannoma looks like. You have the presence of tumor cells present in a palisaded manner with small eosinophilic areas, that is Verrucke bodies seen in schwannoma. Next, this gets us to our next question, that is the question that was asked was large friable vegetations is seen in infective endocarditis. Again an easy one, large friable vegetations. So I thought let's go a step further. This was the question, but let's go a step further and compare the 4 vegetative endocarditis. There are 4, starting with RHD, rheumatic heart disease, which shows multiple warty vegetations along lines of closure of heart wall. You're able to see these multiple wart-like vegetations along lines of closure. RHD, rheumatic heart disease. Infective endocarditis shows large friable vegetations. It's a large friable vegetation which can embolize. So embolizations are common. Next, NBTE, non-bacterial thrombotic endocarditis. NBTE, which infection is present? None. It is non-bacterial, it is sterile in nature. So it is sterile. As a result, it shows the presence of bland vegetations. So again, embolizations are common. Again, embolizations are common. And the last is Libman sac endocarditis. Libman sac, which shows vegetations on both sides, upper surface as well as the undersurface, but more common on undersurface of heart wall, Libman sac endocarditis. Next, this gets us to our next question, that is diagnosis. Image was given with history of atrophic gastritis. What you see here is the presence of large oval RBCs, macroovelocytes with a hypersegmented neutrophil. Macroovelocytes with presence of hypersegmented neutrophil. Next, so this is a case of megaloblastic anemia. This is just on the image. Now the history is being given of atrophic gastritis. That is, this is a case of autoimmune gastritis. Most common cause of megaloblastic anemia. Most common cause of atrophic gastritis, autoimmune gastritis. It is autoimmune, so it has antibodies against intrinsic factor leading to megaloblastic anemia. Next point. Another important point to be noted in this slide is this cell. Have a good look at this. This is a nucleated RBC which shows nucleocytoplasmic asynchrony. This is a nucleated RBC showing nucleocytoplasmic asynchrony. It has a large immature nucleus with fully hemoglobinized cytoplasm. Nucleocytoplasmic asynchrony. That is again a feature of megaloblastic anemia. Next point. So autoimmune gastritis is the most common cause of atrophic gastritis. Next, it is the most common cause of chronic gastritis without H. pylori. Very obvious. Autoimmune. Antibodies against self-antigen. That is, it has antibodies against H plus, K plus, ATPase and intrinsic factor. So HCl is reduced. This was given in the history. Megaloblastic anemia with atrophic gastritis, autoimmune gastritis, vitamin 12, B12 deficiency. Next, the sequelae of autoimmune gastritis. First point, it is associated with carcinoid tumors, adenocarcinoma, stomach and pernicious anemia. The only point to be noted here is most common site of adenocarcinoma stomach after autoimmune gastritis is fundus of the stomach. This is important. Most common site after autoimmune gastritis, fundus. Next, this gets us to our next question, that is diagnosis. What you see here is this image was given. This first image was given in which you see the ecole forms of Plasmodium falciparum. देखो बच्चे, have a look at the image. You're able to see ring forms. These are the two rings. You're able to see ring forms with Morier dots. Plasmodium falciparum. The gametocyte. This is the banana shaped gametocyte, falciparum. Versus, have a look at the next one, that is malariae. It shows the presence of an amoeboid gametocyte. This is the amoeboid gametocyte in the RBC, in which the RBC is larger, the gametocyte is smaller. Plasmodium malariae, amoeboid gametocyte, versus vivax, in which the gametocyte completely fills the RBC. Easy to remember when you are going for viva, make it large. Vivax, it's large, Plasmodium vivax, macrogametocyte. Next, vivax has a single ring with Schaffner's dots. So we have seen all three: falciparum, malariae, vivax. This is the question that was asked: malariae, falciparum, ecoliform. So this gets us to our next question, that is initiator of thrombosis. Easy, pretty straightforward. The main initiator of thrombosis is endothelial injury. Let us have a look at this. The virtuous triad in thrombosis. The virtuous triad. It has three aspects. The main is endothelial injury, hypercoagulability and abnormal blood flow. The most common cause of hypercoagulability being factor 5 laden mutation. All these in turn lead to thrombosis with initiating event being endothelial cell injury. Next, this gets us to our next question, that is 25 male who is extremely tall, 6 feet 5 inches, early diastolic murmur with pedigree chart analysis. The history itself is pointing you towards Marfan syndrome, which is autosomal dominant. But let us not be biased with the history. Let us look at the pedigree chart in itself. What you see is the first generation, the parent is affected, 50% of the kids are affected. Next, whenever a parent is affected, 50% kids are affected. 50% are affected. This is classical autosomal dominant. I need not explain the pedigree chart in detail. This was an easy one. Whenever you get a pedigree chart, first rule out in this sequence, that is mitochondrial, followed by autosomal dominant, followed by autosomal recessive, followed by X-linked recessive. Go in this sequence and you will not go wrong. Next, this gets us to our last question in pathology, which is the correct statement regarding Huntington's chorea. Huntington's, in usually all my live classes, is one of my favorite topics because I'm a house freak. I love watching House MD, and one of the doctors in House, that is 13, suffers from Huntington's disease. Which is correct? It is a trinucleotide mutation related disorder. This is correct. Next, the trinucleotides being repeated in Huntington's is CAG. Hunter keeps the animal in cage, CAG, which are getting repeated in the coding region. Fragile X syndrome, the trinucleotides are CGG, which are in non-coding region. Huntington's, CAG, coding region. Next, it is not loss of function, false. Abnormal repeat of CUG, nahi bache, CAG. Next, abnormality due to mutation in 6. No, it is abnormality due to mutation in chromosome 4. So, which of the following is correct? The answer is A. The answer is A. It is a trinucleotide expansion disease. Done. So this takes care of your pathology discussion, and I hope majority of the questions you were able to do right, at least in pathology. In NEET, the anatomy, path, ENT, anesthesia, forensic were comparatively easier as compared to the surgery and medicine portions. So needless to say, bestest of luck for the rank and take care.